distilling from all these trials, what is your personal approach to treatment in a newly diagnosed patient that presents to your clinic? Let's take it from Dr. Ganti first.
There are a lot of things to be considered when starting patients on treatment. One of the important things that I have encountered in practice from a logistics standpoint is a lot of these patients may have to start treatment in the hospital, and there is some logistical issues with getting the checkpoint inhibitors while the patient is in the hospital. So oftentimes we have to start them with platinum etoposide, get the first cycle in the hospital, and then once they are in the outpatient setting, then add the checkpoint inhibitor afterwards. As far as deciding between which checkpoint inhibitor to use, the one striking thing that I found from both the Empower 133 and the Caspian studies is that even though there was some slight differences in the inclusion and exclusion criteria, as Dr. Chang mentioned about asymptomatic brain mets being allowed in the Caspian study, it is striking how similar those results are, suggesting that this difference, this benefit with checkpoint inhibitors is a real benefit. Oftentimes you see when you have multiple different studies that some studies show more benefit as compared to the others. But if you look at all four of these trials that we've talked about so far, forget the statistical significance part of it. If you look at the benefit, the magnitude of benefit, the difference in benefit, the absolute overall numbers, they are so strikingly similar to one another, suggesting that this is a real benefit. And based on that, I would suggest that all of these patients should be treated with a checkpoint inhibitor in the first line setting. My personal preference, again, has to do with where I live and the distances with which people have to travel in order to come and visit me. If you look at Empower 133, it was an every 3-week regimen with the maintenance given every 3 weeks. The Caspian study was chemotherapy given every 3 weeks with the maintenance given every 4. And I have had patients tell me that they would do whatever if they can make fewer trips. And so in patients who come to me from 3-4 hours away, I tend to use durvalumab, whereas patients who live close by and don't have problems making the trip, then either option would be fairly reasonable.
Thank you so much, Dr. Ganti. Now let's turn on to Dr. Shang. Dr. Shang, which regimen are you using in your own patients? And does your clinical experience match with what has been seen in the clinical trials that we just saw?
Yeah, I think, again, the fact that both Empower 133 and the Caspian trial showed very similar overall survival, I think provides good options, validation, number one, and good options for our patients. You know, I think both of them are good drugs. I think within the non-small cell space, we've had experience using both drugs. Atezo is very well tolerated, and durvalumab we've used for consolidation for stage 3 non-small cell, also well tolerated. I will say that with the COVID in this era, we did look at converting our Atezo every 3-week to every 4-week administration, and for durvalumab we also considered doing it every 6-week, just to keep people out of the office, out of the healthcare system if we could. You know, I think that for patients with asymptomatic brain mets, I would prefer durva. I agree with Dr. Ganti that many of these patients are sick and they start out in the hospital, and we end up starting we can't start the immunotherapy in-house, so we end up starting it afterwards. Are they interchangeable? I don't think that we have information that says that one is clearly different than the other. So I would say that, you know, aside from the brain met issue, that we could probably use either one, and I have used both. I think clearly initially we used the Atezo that had the FDA approvals sooner, and so we certainly were using that, but now I have been using the durvalumab as well. And then I would just mention that one issue that constantly comes up in our tumor board is whether or not to if the patient has persistent disease, do you consider thoracic consolidation? It's a fight that we have every week between the rad-oncs and the med-oncs, because the rad-oncs say, you know, gee, it's certainly tolerated well with IOs, the radiation, and we think that we can have a better benefit. But clearly, the trials did not include thoracic consolidation. So I think if you're a purist, you really try to follow the data. So for me personally, unless there's really a clear reason to use radiation, for example, the patient's symptomatic and there is a need for some sort of local effect, then I hold off on that. But I know that that's a bone of contention. I don't know what you guys do.
I agree. I mean, that has been a challenge. So my practice, what I tend to do is, if someone has had good response outside the chest and has a residual disease within the chest, of course, we don't know if this is inflammation, dead tumor tissue. I would tend to at least talk to the patient about possibly considering thoracic radiation. Again, I understand that neither of the trials allowed it, so it is a data-free zone, if you will. But just given what we know about the benefits of thoracic radiation and the kinds of people that it will benefit, I would tend to offer at least that small proportion of patients thoracic radiation. If I see a good response in the thorax, more than 90% shrinkage, and there's been a good disease response outside the chest, then I'm not so sure that those individuals necessarily need added radiation to the immunotherapy. I agree that we've done radiation with immunotherapy in multiple other diseases, and the combination seems to be well tolerated. We've not had too many untoward side effects in that setting, so I don't have any problems with that. But given that these trials did not include them, I would not offer it in everyone, but just a selected proportion of patients in whom I think adding the radiation would help improve the quality of their response.